Buenas tardes a todos. Para mí es un placer moderar esta mesa, que creo que es de indudable interés en un congreso de insuficiencia cardíaca, volvernos a centrarnos en el ventrículo derecho, que sigue siendo en gran medida un enemigo difícil de batir. Y vamos a tener dos perspectivas distintas. Cómo se adapta el ventrículo derecho a la sobrecarga de presión en el contexto de la hipertensión arterial pulmonar, y a continuación veremos la sobrecarga de volumen en el contexto de la insuficiencia tricúspide. Son dos aspectos distintos de la fisiopatología del ventrículo derecho, ambos muy interesantes. Para ello tenemos la enorme fortuna de contar con dos ponentes absolutamente expertos en la materia, que creo que nos van a poder ilustrar y dar buenos consejos de cómo tenemos que enfocar estos dos tópicos que muchas veces se nos atragantan en la práctica clínica. Vamos a empezar con el doctor Stefan Rosenbach. Como ya sabéis, por las sesiones previas, haremos primero las dos sesiones de los ponentes y después será la discusión. Las ponencias serán en torno a los 20 minutos y luego podremos mantener una discusión sobre este tema que creo que va a ser de indudable interés. El doctor Stefan Rosenbach, que trabaja en el Heart Center de la Universidad de Colonia, de Alemania, es un gran experto en este tema y que además tiene importantes publicaciones, muchas de ellas muy bien estructuradas y que nos han mandado ya mensajes muy claros. Por tanto, creo que vamos a tener la oportunidad de poder aprender mucho con él. Dr. Stefan Rosenbach, welcome to this Heart Failure Congress, and when you want, you can begin your presentation.
Pilar and dear colleagues, first of all, thank you very much for this kind invitation to this, as I view it, very important session on your cardiology Congress. It's a pleasure to be here and to contribute, although unfortunately we can still not travel, but we'll make the best out of it this way. So the task you gave me is to focus on the adaptation of the right ventricle to pressure overload in the context of pulmonary arterial hypertension or pulmonary hypertension as a whole. And when we, in cardiology, think about left ventricle versus right ventricle, I think the first thing that we have to address is that this is not the same. The right heart obviously is not an appendix to the left heart, and it's just not the same myocardium, not the same tissue as compared to the left heart, and this starts from development. So if we look at the developmental process of RV versus LV, there are fundamental differences that we don't want to address in detail here, but that we have to keep in mind then if we speak about pressure overload versus volume overload in the right heart. And if we now focus on the failing heart, because this is what we ultimately see in our patients with pulmonary hypertension, but if we look at the failing right heart in a bigger context, there may be pressure overloaded right ventricle versus volume overloaded right ventricle. And I guess this is the main topic of this session here, to distinguish between the two. And obviously there is also cardiomyopathy of the RV as another potential cause of right ventricular dysfunction, such as in ARVD. So let's focus on pressure overload in the context of pulmonary hypertension now. So in this context, we have an increased afterload of the right ventricle, which is caused by diseased vessels in the pulmonary circulation. And in the case of PAH, we're facing functional, but also structural changes of the small pulmonary resistance vessels, causing an increase in pressure, causing an increase in resistance, which then represents an increased RV afterload. But this echo image here very nicely shows you that we cannot completely differentiate between pressure and volume overload, because what we frequently see as a consequence of pressure overload is a certain degree of dilation of the right heart, leading to functional MR. So what I just want to highlight here is that in most cases, pressure overload leads to changes in the right heart that will then also lead to volume load in addition to pressure overload in the context of pulmonary hypertension. So we have to keep that in mind. And it's not only true in PAH, it's also true in PH, for instance, in PH in left heart disease, where we have a pathophysiological sequence from the left heart into the pulmonary circulation, causing an increase in pressure. If that persists for a longer period of time, pulmonary vascular function may also decline, leading to a decrease in pulmonary artery compliance and an increase in resistance in this context. But in any case, any left heart disease will also represent an increased afterload for the right heart under resting conditions, but in particular with exercise or volume load. And a very prominent example here was published from the Meyer group, looking at the interrelation between left heart, pulmonary circulation, and right heart, in this case in patients with diastolic heart failure, where the investigators have looked at changes in left ventricle versus right ventricle over time. And what they found is not much happened over a time period of roughly 4 weeks in the left heart, but there was significant changes over time in the right heart, and both prevalent and incident right ventricular dysfunction were determinants of poor outcome in patients with HFpEF. So it's not restricted to PAH. And now if we compare pressure versus volume load, and we'll hear about volume in detail in the next talk, there are fundamental differences in hemodynamics, particularly looking at the pressure volume relationship when we distinguish between pressure load and volume load. So fundamental differences, but again, we cannot look at this completely isolated as two isolated conditions. And in the experimental setting, there was a nice study published 10 years ago, which very nicely directly compared the impact of pressure versus volume overload in an animal model under presumably the same experimental conditions. And in this case, pressure load was induced by pulmonary artery bending in these mice, and volume load was induced by creating a shunt. So it's important to note the differential responses of the RV to abnormal loading conditions, particularly those two that we spoke about. So if we here look at the end-diastolic and systolic volumes, obviously volume overload will primarily lead to a more of an eccentric hypertrophy of the right ventricle as compared to pulmonary arterial banding. And this is exactly what is shown here. And this has consequences also on stroke work and on wall stress, where here we see the opposite. In this case, pressure load as induced by PAB had more impact on the stroke work and wall stress as compared to volume overload in this context. And again, we see fundamental differences in the PV relationship under these conditions. And if we now focus on the morphological changes in right heart, and in the images at the top, you see RV, and then below you see LV under these conditions in control, pulmonary artery bending, and shunt. And what you see is that we have an increase in right ventricular weight as compared to body weight in both scenarios, pressure and volume load. But if you look at the cross-sectional area of myocytes, then it becomes apparent that cardiomyocyte hypertrophy particularly occurs with pressure overload. And in this specific context here, the investigators have also looked at molecular changes that are mentioned below, but I don't want to go into much detail here. So if we summarize this, there are specific features of the pressure-loaded right ventricle that include cardiomyocyte hypertrophy, also a degree of ventricular dilation. This is exactly what we see in our patients with pulmonary hypertension, pulmonary arterial hypertension. And the dilation of the right heart then leads to the D-shaped LV, or in particular a systolic septal flattening and paradoxical septal movement. But we also have extensive fibrosis, inflammation, metabolic remodeling in the RV has been described, and we already talked about the changes in the pressure loops and the pressure volume relationship. So in addition to the myocardial architecture and its changes during different loading conditions, we see specific changes directly in the myocardium that occur at the level of the cardiac myocytes, but also at the level of the interstitial space and the fibroblasts. And in this context, adaptation of the right ventricle to an increased afterload obviously is of utmost importance. And I just show you one example here from Barry Borlaug's group at Mayo, looking at abnormal RV to PA coupling, as shown in the lower part here. In addition to changes in the LV, we see abnormal RV to PA coupling in patients with HFpEF that can be found with exercise. So we don't see necessarily all these changes under resting conditions, but sometimes we need to exercise patients to uncover such deficiencies in the adaptation process of the right ventricle. We have many examples in PAH, but I show you this here as one example, again, that it's not restricted to PAH in this context. So coming back to PAH, this image has been shown over and over again, but I think it's really important to understand again that we may have a normal condition, then changes in the pulmonary circuit may happen that alter hemodynamics over time, and then we have an adaptation of the right ventricle that works for a certain amount of time, but ultimately it will lead to RV failure at later stages when patients then decompensate, but right ventricular ejection fraction and other measures are impaired much earlier before the right ventricle fails. And one important question here is this reversible? So are the changes in the RV that are due to pressure overload, presumably, are those changes reversible? And let's focus on CTEPH for just 1 second, because in this context, if we have patients with CTPH who are operated on in terms of pulmonary endarterectomy, in this case, we can be very efficient in lowering pulmonary vascular resistance and therefore RV afterload, and in many cases, even normalizing this condition. So it's important to note what we have learned here, because if we succeed in more or less normalizing pulmonary vascular resistance, we have learned over and over again that there is a tremendous regenerative capacity of the right ventricle if we normalize afterload. And that we have to keep in mind. So that's CTEPH. What about PAH? There has also been a recent study that focused on the right ventricle and potentially reverse RV remodeling in the context of PAH and medical treatment. And this study was conducted, called the REPAIR study, was conducted with an endothelin receptor antagonist. And it's important to note what's shown at the bottom. This treatment could have been initiated alone in treatment-naive patients, or it could be initiated alone in patients who were already receiving background therapy, or it could be initiated as one component of combination therapy with a PDE5 inhibitor. So all this was possible when patients were enrolled into the trial. And then MRI and right heart cath were performed at baseline and at week 26. Week 26 was the time point of the primary endpoint here, and the co-primary endpoint in this study were the changes in PVR as assessed by right heart cath and in stroke volume, RV stroke volume as assessed by MRI. And what was found was that at 26 weeks, PVR decreased by 38% in this study, given the different treatment strategies that were allowed here. And importantly, if we then look at the MRI images here, and we look at the RV, but also the RV to LV interaction, it was found that there is a quite substantial reverse remodeling that can also be detected with medical therapy in PAH if we reduce pressure, if we reduce afterload with the treatments that are out there. And when we look at the other component of the co-primary endpoint here, the reduction in PVR correlated with an improvement in the RV stroke volume at week 26 in these patients. So what we found is the reduction in afterload, an improvement in RV remodeling and structure, and an improvement of RV function in this context. And the question is, how good do we have to be to really have relevant effects on reverse remodeling in the RV? And there have been some data that were published and summarized here, indicating that we probably need to reduce the PVR by roughly 30 to 40% before we can expect reverse remodeling as a consequence of afterload reduction. And in this context, if we now focus on one other recent study, namely the Triton study, where initial triple combination therapy was compared with initial double combination therapy in patients with newly diagnosed PAH, there was no difference in PVR reduction between those two groups. But what was very nicely shown that we can achieve a lot by establishing double combination therapy. So in this case, PVR was reduced by a little bit more than 50% in both cases. And that is in line with data that we may also detect in our clinical routine care. These are data from our Cologne Center looking at different hemodynamic measures at baseline in blue, and then at approximately 6-month follow-up after initiation of, we called it rapid sequential combination therapy here, with an ERA and a PDE5 inhibitor. And if we focus on the upper right and we look at pulmonary vascular resistance, we see exactly the same here, roughly 50% reduction as was seen in Triton. One additional piece of information here may be that if we look at patients, younger patients with what we call classical PAH, and then elderly patients with PAH and comorbidities, both improved in PVR, but the PVR was lower to start with in the patients with comorbidities, and also the decrease then in PVR was less pronounced. But if we look at other invasive hemodynamic measures, of which we have learned that they are important for prognosis, namely stroke volume index and pulmonary arterial compliance, those two subgroups appear to show a very similar pattern of improvement after initiation of treatment in this case. And then we have newer compounds. If we think about reduction in PVR and reverse RV remodeling, many of you probably have heard of sotatercept, a very new compound that was just investigated in a phase 2 trial in patients with PAH. And importantly, in addition to all pre-existing therapies, there was a substantial further reduction in PVR that could have been achieved with this compound, and a phase 3 trial is currently ongoing. So the reason I show this is, obviously, we are more and more capable with our medical therapies for PAH to sufficiently reduce pulmonary vascular resistance. And as we have learned, we can reverse this remodeling of the RV. This is probably important news for the patient. And if we look at risk stratification and the prognostic value of hemodynamics in this context, and these are data from the French registry that have very nicely shown that probably the best predictor of survival when we look at repeat right heart cath during follow-up in treated patients is stroke volume index. So if we achieve a significant improvement or a certain level of RV function while patients are in treatment, then that's probably a good thing. And if we look at the current version of the ESC-ERS guidelines and we look at the risk assessment, there's obviously imaging, but the imaging only mentions RA area and pericardial effusion so far. Hemodynamics focus on RAP, cardiac index, and mixed venous oxygen saturation. So some things may change based on some of the data that I have just shown you. And in this context, to look more closely from a clinical perspective at the RV in our patients may give us additional information. And these are some nice data from the Sheffield group looking at the RV precisely by cardiac MRI. And what they have done is they have looked at different measures, as you see here, the RV and systolic volume index versus the LV and diastolic volume index, and also RV ejection fraction were important for risk stratification and prediction of mortality in these patients. And if we look at this here, patients who reached certain thresholds here using cardiac MRI, both at baseline on the left and during follow-up in the middle, and then the change is shown on the right. This, in addition to what we have, seems to better help to predict survival in these patients. I show this because that obviously reflects remodeling or reverse remodeling of the RV in the context of pressure load. And there was also a systemic review and meta-analysis of MRI data in this context. And this work included 22 studies, almost 2,000 patients. And what we see here is the importance of RV measures and RVESVI in particular, but also left ventricular measures that were able to predict mortality. And that makes sense after all. So after all, a decrease in RV size and systolic and an increase and a decrease in LV measures was associated with poor outcome. And that makes sense because obviously if the right ventricle is dilated, we have septal bowing towards the left. So we have left ventricular compression. So the left ventricle becomes smaller with many consequences if we have a dilated right ventricle. And our goal should be to reverse this and also enable the LV to become larger again. And there were some data published recently on echo parameters of LV function and the importance for survival in patients with PAH. So if you look at global longitudinal strain in this context, it appeared important. So the scenario here is that due to increased afterload and pressure load, we have RV hypertrophy, but we also have RV dilation and dysfunction. We have an interaction between right and left heart, and also the left heart impairment appears to be important for survival. So if we summarize this, the right and left heart interaction, what happens in the context of pressure load to the right heart is we have right ventricular failure leading to systemic congestion. We also have diminished LV function due to chronic underfilling, and that has been previously shown also cardiomyocyte atrophy on the left side. So we have systemic venous congestion. We also have systemic low output. And the combination of the two triggers a systemic inflammatory reaction that then affects multiple other organ systems. So we have to keep that in mind. And these are my last two slides, because I think in clinical cardiology these days, when we also have interventional approaches to treat the tricuspid valve in the context of tricuspid regurgitation, we have to diagnose these patients very precisely. And I think whenever there is a high probability of significant pulmonary hypertension, these patients should or must undergo right heart cath before we touch the tricuspid valve, because in the context of severe RV afterload. If we close that valve, we may not really help these patients. So in the case of precapillary PH, obviously targeted pH therapy would be the primary thing to do. And if we then monitor tricuspid regurgitation in this context due to reverse remodeling of the right heart, we can also expect and we can detect also an improvement of TR in this context. When we, however, decide to repair the tricuspid valve, it may also be important to follow these patients and see what happens to the RV and also monitor pulmonary pressure in addition, because after all, as I mentioned in the beginning, pressure load and volume load are connected here. And one open question is, if we succeed in treating pulmonary hypertension and we lower afterload, but patients then remain with significant TR, would that be an additional target for these patients to touch? Nobody knows so far. So this is ongoing research. And I think in this context, we have to get better here. And with this, I stop here and I thank you very much for your attention.
Thank you very much, Dr. Rosenberg. We are going to move to the next presentation. Question and answer is in the end of this roundtable. Now it's my pleasure to introduce Victoria Delgado García, que trabaja en el Centro Médico de la Universidad de Leiden. Es una gran experta en ecocardiografía y nos va a hablar precisamente de la adaptación del ventrículo derecho a la sobrecarga de volumen en el contexto de la insuficiencia tricúspide. Cuando quieras, Victoria.
Muchas gracias, Pilar, y un honor para mí participar en este simposio de la Asociación de Insuficiencia Cardíaca de la Sociedad Española de Cardiología. He preparado un poco las diapositivas en inglés pensando que el profesor Rosenkrantz podría también seguirlas, pero hablaré en inglés tal y como me han dicho. These are my conflict of interest, and after the excellent talk of Professor Rosenkrantz, actually we know that the right ventricle is gonna remodel differently depending on the cause that leads to the injury, either if it's a pressure overload or a volume overload. And the tricuspid regurgitation is a very frequent valvular heart disease and it has a very heterogeneous etiology. We can come from a pulmonary arterial hypertension or chronic pulmonary embolism, or even most frequently secondary to left ventricular side heart failure or after intervention of a valve of the left side. So that makes that the assessment of the pathophysiology or the function and the remodeling of the right ventricle may be challenging, and it has important prognostic implications, and the treatment may be ideally target the etiology that causes the tricuspid regurgitation, but sometimes is rather difficult. So basically, in severe tricuspid regurgitation, the cause of the severe tricuspid regurgitation is most of the times the dilatation of the left ventricle, but the right ventricle is also the victim of that tricuspid regurgitation, because due to the volume overload, there is much more remodeling, much more dilatation and failure of coaptation of the tricuspid leaflets. But as I said before, there is a very heterogeneous etiology, and that can lead us to some peculiarities and to also different responses to the treatments. As Professor Rosenkrantz indicated in his lecture, we can have a volume or a pressure overload that leads to myocardial ischemia, myocardial disease. This myocardial injury and stress leads to the ventricular remodeling with activation of the neurohormones and cytokines and altered gene expression. And depending as well of how the time course of the myocardial injury goes, this remodeling may be different. But eventually, all of them leads to right ventricular dysfunction and dilatation and a vicious circle that leads to the volume overload and more injury of the myocardium. When to detect the patient that needs to be treated in order to block or to halt this progression and this vicious circle? Here, for example, I present you one of my patients who unfortunately died. This was a patient who was diagnosed with hypertrophic cardiomyopathy. He also had later on progression of left ventricular dilatation, mitral regurgitation that was treated with MitraClip. He also had an ICD and developed tricuspid regurgitation. And as you can see on the upper figures, the tricuspid regurgitation would have been qualified maybe not as severe as we see, and it could be probably related to the presence of the pacemaker. And at that moment, the patient was asymptomatic, and I put it between brackets because the patient was already on diuretic treatment. So for me, it's very difficult to understand how a patient can be asymptomatic when he's already treated with diuretics. This patient developed later on, 3 years later, NIA class 4 symptoms, and you can see here on the echo below that there is dilatation of the right ventricle, malcoaptation of the tricuspid leaflets, and much more severe tricuspid regurgitation. And at that moment, the patient was already too late for intervention, and eventually the patient died. So how to evaluate the right ventricle in these patients, and how to predict which are the patients that need to be treated in order to prevent that this ventricle remodels. Echocardiography is the imaging technique that we have much more available, and we all use as a first imaging technique to evaluate these patients. But the disposition of the right ventricle is very peculiar. It has no continuation, like for example in the left ventricle with the mitral aortic continuity. It has a right ventricular outflow tract in the pulmonary valve is completely separated from the tricuspid valve. We need to assess the right ventricle with two-dimensional echocardiography on different views, and here you have some of them. The parameters that define abnormal are here in this table presented, and are the American Society of Echocardiography parameters that coincide as well with the European Association of Cardiovascular Imaging. And we have a right ventricular basal diameter of more than 4.2 centimeters. And probably one of the most frequent also used is the tricuspid annular plane systolic excursion, the TAPSE less than 1.6 centimeters. We can also use tissue Doppler with the peak systolic velocity, that if it's less than 10 centimeters per second is indicated that it is abnormal. And we have as well the fractional area change, which is just the change of the area in systole and diastole of the right ventricle, and if it's less than 35%, is going to be abnormal. But you have to be careful, particularly with this last parameter, because depending very much on how we image the right ventricle, we can have a different fractional area change. And here is when we have sometimes dilemmas in the clinical practice. Here, this is the short axis of the left ventricle and the right ventricle. And depending on how you are cutting the right ventricle, if it's more posterior or more anterior, you can have a fractional area change that ranges from 20%, which would be a very reduced right ventricular systolic function, to 60%, that would be normal. So this indicates to us that with echocardiography, we need to be a little bit more patient, a little bit also more accurate, and try to evaluate other parameters in order to have the combined evaluation of the right ventricle. Perhaps nowadays we have in our echo labs the possibility to acquire three-dimensional echocardiography, and this is a much better parameter of evaluation of the right ventricle than two-dimensional echocardiography. It has shown a good agreement and reproducibility as compared to CMR, and that helps significantly to evaluate the patients. So therefore, the European Association of Cardiovascular Imaging and also the American Society of Echocardiography recommend to acquire more and more three-dimensional volumes. And as you have seen before, if I can advance my slide, that I have problems for that. I hope that the technical department can help me. Magnetic resonance is the imaging technique of reference to evaluate the right ventricle. I cannot advance the slide. I don't know if the technical department can help me on that. to advance it directly. I can also try back and then forward again. Yeah, no. Perfect. Thank you very much. So CMR is a very complete imaging technique as well, and it has an excellent spatial resolution and very good temporal resolution. We can assess the severity of the tricuspid regurgitation, which is sometimes as well difficult with echocardiography. And we can assess as well the volumes of the right ventricle. If I can have the next slide, please. And we can even measure as well the pulmonary hypertension. Perhaps one of the parameters that has been less explored in CMR is the assessment of the tissue. Here you can see the assessment of the right ventricular volumes. We can have several software and recreate the model of the three-dimensional cavity as well of the left ventricle. And probably we'll have the same problem on the next slide if they can put the slide, because there are many videos. Perfect, thank you very much. You can assess as well the pulmonary hypertension. However, CMR is a technique that we would like to have much more often in our services and much more available, but is time consuming. And I didn't put on slide, but there are sometimes artifacts, particularly patients, for example, that they have a pacemaker. Sometimes we need to have a very good skills in order to acquire the data and not have artifacts that can blur the image and the assessment of the right ventricle. One of the parameters that CMR could help us is as well on the tissue characterization. But as you have seen, depending on the etiology that leads to the right ventricular dysfunction, and particularly probably is more frequent in patients with severe tricuspid regurgitation, the walls can be very thin, and we cannot assess the presence of myocardial fibrosis as good as we do with the left ventricle. One of the parameters that has been proposed in order to assess earlier the presence of systolic dysfunction of the right ventricle is the assessment of myocardial strain. And we can do with echocardiography, we can do with CMR as well. But basically what it detects is the shortening of the myocardium in the longitudinal direction. And in this study, including more than 800 patients, all of them with moderate and severe tricuspid regurgitation, you can see that the presence of, or the number of patients that were having right ventricular dysfunction when we were applying right ventricular strain was much more than when we were applying two-dimensional echocardiographic techniques such as the fractional area change or the TAPSE. So even though longitudinal strain can be also load dependent, it detects earlier or a larger amount of patients that are having already problems in the right ventricle. And this has prognostic implications because patients with a right ventricular longitudinal strain, which is lower than 23%, they have worse outcome in this particular group of patients with severe tricuspid regurgitation. And this is incremental to other parameters. As Professor Rosenkrantz also said, it's important to take into account the pulmonary pressures. And that is particularly important, for example, in patients where the initial insult to the right ventricle is the high afterload. In that case, for example, in our population, one of our fellows, Federico Fortuny, had the idea of evaluating the ratio between TAPSE and the systolic pulmonary arterial pressure as a measure of the right ventricular pulmonary arterial coupling to predict the outcome of those patients. And you can see in this spline curve that the lower the ratio was, the higher the risk for mortality. You can see also in this histogram, which is the distribution of the population, the majority of the patients were between 0.2 and 0.4. But if we take into account the cutoff value of the hazard ratio of 1, around 0.3 was the value where the hazard ratio starts to increase for the occurrence of all-cause mortality. The population was then divided according to this ratio of 0.31, and those patients with the lower ratio or with a lower ratio, they had a worse outcome, as you can see in this Kaplan-Meier curve. So it's important also to assess the right ventricular pulmonary arterial coupling in order to better characterize these patients. But one of the most important questions as well that in the previous talk was alluded to was, when do we treat these patients? And we all have the impression that we are referring these patients very late, because the treatment is going to be, in principle, tricuspid valve surgery and tricuspid valve repair, but the surgeon is going to operate on those patients when they have symptoms, and if they are asymptomatic, they may not accept to operate this patient. So we did the exercise of trying to find in our population of patients with tricuspid regurgitation, trying to stage these patients according to the staging of right ventricular failure proposed by the European Association of Heart Failure. And we have stage 1, which are all the patients at risk for heart failure without right ventricular dysfunction and without signs or symptoms of right heart failure. So TAPSE at least of 17 millimeters in NIA class 1 and not using diuretics or not having edema. Stage 2 would be right ventricular dysfunction without signs or symptoms of right heart failure. So TAPSE already reduced below 17, NIA class 1 and not using treatment or not having edema. Stage 3 would be the right ventricular dysfunction with prior current sign and symptoms of right heart failure. And stage 4, right ventricular dysfunction with refractory signs and symptoms of right heart failure at rest, requiring their specialized interventions. And you can see that in our population, which includes more than 1,200 patients, those with moderate tricuspid regurgitation, a significant proportion were already in stage 4 and in stage 3, 29% and 52%. And this was even more in patients with severe tricuspid regurgitation. When we test this classification against the outcomes of all-cause mortality, you can see that the patients who had the worst prognosis were the ones in stage 4 and stage 3, but you can see already that stage 2 had also worse outcome than stage 1. That means that probably we should need to refer these patients much earlier and perhaps even treating them or operating them when they are asymptomatic, they have a good right ventricular systolic function. Perhaps the transcatheter treatments may be a solution in order to treat with less invasive treatment these patients. And if then the tricuspid regurgitation recurs, then we could try surgery that needs to be demonstrated in further studies. But indeed, the advent of the transcatheter therapies has shaped more or less this field and has helped us also to put a focus on patients with severe tricuspid regurgitation and not considering it as a benign valvular heart disease. So in conclusion, I think that the tricuspid regurgitation is a very heterogeneous pathology, has multiple etiologies, and the pattern of right ventricular remodeling may be different in response to the pressure overload or the volume overload. But the more or the longer we have the patient with severe tricuspid regurgitation, the more we will see that eventually end up with a ventricular dilatation and even more tricuspid regurgitation. The assessment of the right ventricle remains still challenging, but I think that applying multiple parameters based on echocardiography, and remember also the three-dimensional echocardiography can help us. Magnetic resonance is considered the reference standard for the assessment of the volumes. And we also need to take into account the afterload. And all these parameters have important prognostic implications. And with this, I'm happy to take on questions or start a discussion. Thank you very much for your attention.
Thank you very much, Victoria. It's time to the discussion. We have now a question from Victoria. La pregunta es, ¿por qué está tan mal el ventrículo derecho en los pacientes con insuficiencia tricúspide moderada? ¿Cuál crees tú que es el motivo de esa disfunción tan severa?
I will answer in English, if that's okay, so that Professor Rosenkrantz maybe also can start. So the question was why patients with moderate tricuspid regurgitation, they have reduced right ventricular function. That's a very good question. It could be that, for example, patients with pulmonary hypertension, pulmonary arterial hypertension, we may not see such a severe tricuspid regurgitation than in patients with left ventricular side disease. And at the beginning, the ventricle may not be that dilated, but the function can be already impaired, and we can have already some degree of tricuspid regurgitation. This is why I said that when you have the tricuspid regurgitation, try to see as well which is the cause on the origin, because you could treat the etiology initially, and therefore later on the tricuspid regurgitation can reduce. But if you never think about that, you may delay the disease and you may end up with a tricuspid regurgitation where the etiology may be difficult to discern and the treatment may be too late. And then it comes the question, which will be the ventricle that will recover after intervention? And as Dr. Rosenkrantz said, that's the key question. When exactly we need to start therapy in order to prevent that goes further and to know if it will recover.
And what is your opinion on that, Dr. Rosenberg?
Yeah, I'm unmuted now. I totally agree with what has been said. And perhaps one thing to add would be that, recently I think we have learned how important even moderate TR is for prognosis of patients, and we continue to learn here. And I was always intrigued. I've shown you some examples of reduction in afterload and then reverse remodeling of the RV, but we don't always see that, and may be different if we have patients, for instance, with severe mitral regurgitation, who then have backward congestion in the pulmonary circulation and have tricuspid regurgitation. Then it seems like it doesn't always work that the right ventricle improves afterwards. So I think there are different phenotypes, there are different scenarios that we need to address. But my fear right now is at least in interventional cardiology. So you mentioned the surgeons, that's one thing. And I think that before we touch the tricuspid valve, what we need to do is really precisely characterize these patients and then think and then do something or do not do something. Sometimes that may sound a bit critical, in surgical hands or even in the hands of us as interventional cardiologists, sometimes we may be too fast with decisions. And the tricuspid valve here could be one example where I would say be cautious, but in the end, if there is no significant pH present, then we do have a chance to improve things when we repair the tricuspid valve. And we don't really close it. We reduce the amount of regurgitation. So perhaps we will learn in the future that it's not that dramatic, but the data will have to show us. And related to the question of RV dysfunction, even with moderate TR, yes, you said pH could be an issue. Another issue could be, and we've also learned that from the left side, is that things may change with exercise. So usually we only look at rest. And we have learned, for instance, for functional mitral regurgitation, that this is also prognostically relevant for the patient. And similar things may be true for the right heart and tricuspid valve as well. So then is there a contractile reserve of the RV or not? Things that we need to learn. And I think that at least from a scientific point of view, we will probably see some kind of a renaissance of exercise right heart cath that has already started.
Thank you very much. Other completely different question. Is there a role for pulmonary vasodilators in patients with pre- and postcapillary pulmonary hypertension that get a left ventricular assist device? It's for you, Dr. Rosenberg.
I didn't really understand the question. Is there a role for pulmonary vasodilators in patients with LVAD?
Yeah.
Okay. Well, yes and no. So the politically correct answer would be no. LVAD, we would think about patients with obviously advanced HFrEF, and we would support the LV with an assist device. What we have learned is that if we, by doing this, are able to reduce filling pressures, we will improve pulmonary hypertension, and we will also improve the right ventricle. However, there are some studies that this seems not to always work. So if there is a disconnect between left-sided filling pressures and what we measure in the pulmonary circulation, and I think the data that have been published used the DPG in this context, then we have learned that the outcome of these patients, even after LVAD implantation, is very poor. So I guess what they have then is combined post and precapillary pH. So if things do not improve after an LVAD, patients are at high risk. Again, also in this scenario, we have to know what we do, and we have to characterize the patients as precisely as possible. But I think in these individual, but these are really selected individual cases, one could think of trying a pulmonary, or let's say a pH drug.
And in this scenario, what is your favorite pH drug? PD5, prostacyclin?
I think that, in the context of left heart disease, we have limited data. We have, and I want to emphasize this here, we have no approval, we have no clear recommendations to treat these conditions with pH drugs. That's one thing. If we decide, because we think we have done everything for the left and there is a predominant precapillary component to this pulmonary hypertension, then in my experience, and I think we also have some data on that, PDE5 inhibitors or drugs targeting the NO pathway may be the ones that are best tolerated, maybe better tolerated as compared to ERAs, and we wouldn't really think of prostanoids in this context.
Another question is, in patients with severe tricuspid regurgitation and carcinoid-like etiology with the cancer, how many times we need to wait to repair the tricuspid regurgitation?
Well, that's a very good question if it's reparable, because most of the times needs to be replaced. There are series that they have good experience once the cancer is well controlled and treated, of good replacement. And we had, for example, experience on one case as well, and there are specific protocols from the endocrinologist point of view where you can wait, and if that is controlled, you can undergo for surgery. A specific time, I don't have now the clue out of my head, but in principle, if everybody agrees, they have good result.
Okay. And a question for me, Dr. Rosenbach. There are a cutoff of right ventricular dysfunction for lung transplantation in a patient with pulmonary arterial hypertension? Or we are think to perform a right heart and lung transplantation because the right ventricle is a severe right ventricular failure?
Yeah, very good question, Pilar. After all, I probably wouldn't be so concerned about the right ventricle, even if it's severely compromised, because we have learned, as I have, and I've shown some examples, and obviously lung transplantation would be another way to more or less normalize afterload. So what we have seen also in the context of transplantation is that the right heart usually recovers. So even a very bad RV would not be an indication for combined lung and heart transplantation. And ironically, what we should be concerned about is the left heart in this context, because what we see is that in the early post-transplantation phase, the left heart may be the one that fails, because all of a sudden you allow more flow through the pulmonary circulation, and the left heart may not be able to deal with that increased flow because of the reasons some I have mentioned. The left heart is used to chronic underfilling. We are facing cardiomyocyte atrophy and other things. So for this reason, some of these patients require ECMO in the early post-transplant phase until the left ventricle then adapts to the increased flow.
Thank you very much. Another question from the audience. There are no questions. Okay, I go to do it. Another one. I asked from Dr. Rosenberg, is there a cutoff to don't go ahead with the right ventricle in PH? The same question for you. There are cutoff for no go ahead with the repair of surgery, hemodynamic, interventional procedure or whatever in severe tricuspid regurgitation?
That's also a very good question because there are no really randomized trials to answer that question. I would say that you need to evaluate that patient and see which is the capability that right ventricle has in order to respond if you are going to do a surgery. If you are going to do a transcatheter intervention and you are not going to replace the valve, you also need to be careful, but it's less damage than a surgery in principle. There is no really a clear cutoff value, but when you diurese the patient well and you know that it's euvolemic, you reassess the right ventricle, you can have the several parameters. The lower the TAPSE is, the lower the fractional area change is, the lower the ejection fraction, the harder it's going to be for that right ventricle to recover. So that is what the patient needs to be informed of. When you have, for example, other transcatheter procedures that have been tested, like implantation of the Cabal valves, and basically what you are doing is making as a ventricle also the atrium, there the right ventricular function is really primordial. And if it's not going to work, if it has a very poor function, it's not going to work. And the patient is going to have a very poor prognosis. So there perhaps you need to target more a transcatheter therapy, such as ring annuloplasty transcatheter or an H2H, and let some tricuspid regurgitation still to be there in order for the right ventricle to be able to work. But there is no cutoff value, but the lower you go, the worse is going to be the prognosis.
Thank you very much. It's time to close this roundtable. I think that we have very, very good speakers, and we are talking about a very interesting topic that clearly we need more research on this area, because we need to learn a lot of things. There are a lot of things that we don't know, that we have a lot of doubts, but we are continuing to learn. And perhaps the most interesting news is that cardiologists now are truly interested in the right ventricle. And this is a very good news. Thank you very much for your attention.
Thank you.
Thank you.